recording and introduce him. So I wanted to introduce, and let me know if I'm saying your name wrong, Dr. Shprecher. We're pleased that he is here from Banner Sun Health Resource Institute, which is a movement disorders program director, and he'll discuss movement disorders. He's a neurologist who serves as Banner's movement disorder program director, overseeing patient care, clinical research studies. He specializes in diagnosis, treatment, research for movement disorders, including Parkinson's disease, tics, Tourette's syndrome, Huntington's disease, dystonia, tardive dyskinesia, I always say that wrong, tremors, progressive supranuclear palsy, and multiple system atrophy. He completed his Doctor of Osteopathic Medicine at Lake Erie College of Osteopathic Medicine and a neurology residency at the University of Utah. He completed his Movement Disorder Experimental Therapeutics Fellowship and Master's in Clinical Investigation at the University of Rochester. He's mentoring many students and trainees while serving as the Movement Disorder Division Chief at University of Utah. And he was inspired by personal experience as an individual with Tourette's syndrome. He's dedicated his career to improvement, treatment options, and quality of life for movement disorder patients. His work with the Brain and Body Donation Program is aimed at improving early diagnosis of Parkinson's and related diseases. The ultimate goal is to develop a treatment plan that can prevent these illnesses entirely. And with that, welcome. And one thing before you start, do you prefer us to raise our hands and ask questions, or wait till the end, or what do you prefer? You're on mute. Sorry. Still on mute. It can be *6 or the little mute button. Okay, that's good.
How's that?
That's good.
Yeah, I prefer we can do this as more of an interactive conversation. So as I get to each topic, please use the raise hand, or if nobody else is talking, feel free to chime in as we get to each topic while it's fresh in your mind.
That's great.
So,
thank you.
Yeah, I really appreciate the opportunity to cover this topic. This is just meant to be a really broad overview. First off, just to frame the conversation, so I clarify what specific neurological conditions we as movement disorder neurologists mean when we say this, that we're movement disorder specialists. And then to start by talking about the neurological conditions that are more common, where the mental health conditions and the neurological conditions really overlap a lot. And people who are advocates for individuals with mental illness, often they find themselves advocating for someone who also has one of these neurological conditions. And then in the next part, the final part of the talk, I want to just kind of give you a broad overview of some of the most common side effects of the treatments for mental illness, because a lot of these treatments, while they're life-saving and very beneficial for the mental health condition, can have movement disorder side effects in particular, and just kind of want to explain what are some of the avenues available to you to try to get help for people that you're advocating for if you think they might be having side effects. So when we say that we specialize in movement disorders, we kind of draw the line between movement disorder and motor neuron disease, for example, where motor neuron disease falls more in the neuromuscular realm because it's a muscle nerve problem. But otherwise, movement disorder is a really broad category of neurological conditions where people basically have trouble controlling their interaction with the world around them. They can't control their voluntary movements. But if it's mainly due to weakness, like from a stroke or Lou Gehrig's, ALS, motor neuron disease, muscle nerve problem like neuropathy, that's where the neuromuscular specialty comes in, or if it's a case of stroke, we want to involve stroke specialists. But it's a very broad category. And when people ask, well, what are some of the most common things you see in your clinic? These are maybe the top 10 or 15 conditions. By far the most common reason people get referred to the movement disorder neurology clinics are for conditions in the Parkinson disease family, what we call Parkinson's or Parkinsonism. And Parkinson disease conservatively accounts for about 40% of all the visits that we have in the clinic. Parkinson's are closely related conditions. And then another closely related condition, we say atypical Parkinsonism, if it's something in the Parkinson's family that we still think is a illness where the brain degenerates, so neurodegenerative illness. Movement disorder side effects of medication are one of several reasons that we see patients, and most commonly these are side effects of the antipsychotic family of drugs that are also, as you know, often used to treat depression, bipolar disorder, schizophrenia as well. And then there's a whole wide range of other conditions I'll touch on over the course of the next half hour or 40 minutes. So one of the challenges with having a longer lifespan as human beings compared to the pets and creatures of the world that we care about is that as we age, there's this risk of neurodegenerative illness that goes up, particularly as we get into our sixth decade of life, and even more so as we get into our 80s. So conservatively, 10 or 20% of people will have Alzheimer's by the time they're in their 80s. Some have estimated 5 to 7% of men, but fewer women by the time they're 85. And the prevalence of Parkinson's disease is very low at age 40. It's like 1 in 300,000 or less, but it's 1 or 2 out of 100 by the time we're 65, though twice as common in men as in women. And this is by far, after Alzheimer's and Parkinson's, these are by far the two most common neurodegenerative illnesses, where basically the brain starts to make mistakes taking out the garbage, and proteins that normally should be recycled clump up and cause damage, and then that causes cells to die off at a faster rate than they should from normal aging. So if it's Alzheimer's, it starts more in the memory cells, we call the hippocampus. In Parkinson's, it seems to start mainly in the motor circuits of the brain, particularly those that produce dopamine. So the initial symptom in Parkinson's are the motor symptoms. And if you have a loved one who's been seeing a neurologist or a doctor or clinician for Parkinson's, very often they start off saying you have Parkinsonism, or someone's taking something in the antipsychotic family. We use this term Parkinsonism to refer to these symptoms. And they mainly refer to a slowness of movement where activities we take for granted because they happen automatically, even with repetition, we really have to concentrate on them for them to happen correctly. So in people with this bradykinesia, when they try to write, the penmanship gets smaller and smaller as they go along the page. When they walk, they don't swing their arms the way they should. And in particular with Parkinson's, it's often worse on one side than the other. So there's usually one side of the body where the arm just doesn't swing properly. So that's the bradykinesia. And then patients usually have at least one of these other features. So muscle stiffness, we call rigidity, and tremor. But usually with Parkinsonian tremor, the tremor is worse when their arm or leg is fully supported at rest and often improves with activity. Parkinson's disease is diagnosed still primarily based on the symptoms, but there are some evolving tests that we're starting to use more and more to help differentiate between Parkinson's and other causes of those Parkinsonian symptoms. If somebody has certain red flags that raise concern for a close cousin of Parkinson's, that will help us as neurologists decide if they have one of the Parkinson's mimics, what we call an atypical Parkinsonian disorder. Most common being dementia in the very first year. And if someone has dementia in their very first year of symptoms, that raises concern for a more aggressive form of Parkinson's called dementia with Lewy bodies. Laura, you had your hand up?
I was just reading, Dr. Dr. Schwartz has a question.
Okay,
Why is
great.
it more common in men than women?
There are a lot of medical mysteries when it comes to neurodegenerative illness. This is still one of them. So we still don't know why Parkinson's is more common in men than in women. Some of my colleagues are studying question whether estrogens may somehow be protective.
Yeah.
Now, there's mixed data on that, but that's one theory that's been proposed, is that somehow estrogens may have been protective, and that might explain why there's a difference between men and women. But it's still not clear, unclear.
You know, I know at the European Psychiatric Association a few years ago, and again in the Mexico one, there are a lot of studies talking about the protective factor of estrogen, and that a lot of times women, and this was some of the theories, women that had postpartum, pay attention, and then women after menopause sometimes have their psychiatric breaks, and then, but you see young males more, they're at higher rates, and they're represented in our psychiatric hospitals and institutions at much higher rates.
Yeah, there's a lot of theories, but the bottom line is there's still not a consensus as to why. One other question people often ask, where we do have a little bit more of an answer, is why do the dopamine cells die off first? And it appears dopamine cells have more connections with other brain cells, the more we call synaptic connections, than almost any other neuron. So they have very high energy demands. And so anything that damages those powerhouses of the cell, we call the mitochondria, including basically gunk building up in the system, so proteins that are clumping up, misfolding, causing damage to those powerhouses of the cell, the dopamine cells are much more sensitive to that, which may be why, whether it's Parkinson's or some of these atypical Parkinsonian disorders, they all seem to cause early loss of dopamine cells. With the term Lewy body refers to a collection within neurons, so the larger brain cells, that can be seen with regular light microscope. And it's composed of a protein that stores the dopamine and that's involved in storing and releasing dopamine called alpha-synuclein. And so it's a confusing term because we call it Lewy body dementia, but Lewy body dementia is really an umbrella term that refers to any dementia where the primary cause seems to be degeneration in the brain where manifested by Lewy bodies throughout the brain. So within not just the neurons in that dopamine producing cell region, the substantia nigra, but also the part that houses our learning and memory, we call the cortex. So in people with dementia with Lewy bodies, these Lewy bodies are throughout the brain probably by the time they're diagnosed, and they already have dementia in their first year of symptoms. People with Parkinson's may take much longer to develop dementia, if at all, but whether they have Parkinson's disease and then later develop dementia years later, or if they have that dementia with Lewy bodies with dementia in the first year, collectively, Lewy body dementia is intended to refer to both conditions. What I find, though, is many clinicians still use the term Lewy body dementia to refer to the more aggressive type, dementia with Lewy bodies. And I think it's a term that is more commonly understood in the public, in the media and in lay terms. So Lewy body dementia is probably the one you hear used more often. But not everyone with Parkinson's disease will develop this problem. One important problem with Parkinson's disease, and in particular dementia with Lewy bodies, is people who have it are very sensitive to antipsychotics, even some of the newer ones like olanzapine or aripiprazole. And it can make motor symptoms profoundly worse. but it can also even worsen the dementia problems. And so when somebody is diagnosed with one of these conditions or suspected, then it's important that if a psychiatrist is involved, it's someone who's really familiar with this interaction and kind of understands how to manage psychiatric symptoms appropriately to avoid worsening the motor or the cognitive. There can be a lot of other symptoms besides movement disorder problems and then the cognitive problems. There can be motor symptoms that don't necessarily respond to medications that boost dopamine in the brain, like levodopa. Levodopa is still the mainstay of therapy for these conditions, Parkinson's, Lewy body dementia, because it corrects the dopamine deficiency by giving a precursor to dopamine. However, people can also have softness of the voice that responds better to speech therapy, balance problems that respond better to physical therapy. They may have swallowing issues that require diet modifications guided by a speech therapist. And so we really need a team of allied health professionals and clinicians that work together in managing all these symptoms. Now, before I go into just mentioning about the non-motor symptoms and how this ties in a little to kind of the nature of this group, I want to do an audience poll. So audience poll, we might have to use emojis, and if Lori, if you're able to see kind of how many people use each emoji, I just want to get a sense, how many of you think the answer to this question is either of the following? So which symptom do you think is seen in at least half or more of people with Parkinson's disease? Use the fire emoji if you think it's impaired sense of smell, the scratching your head emoji if it's dementia, cognitive decline, sad face if it's mood anxiety disorders, surprised face if you think it's hallucinations or delusions, or the, oh, I'm overwhelmed face if you think it's all of the above. And then in order to pull up your emojis, you got your three little dots at the bottom and just choose a reaction.
In the chat, there's the little emojis. I'm trying to find the right one.
Oh, yes, you have to open the chat function first. Yeah.
Let me see if, oh, you don't have to. They're there also. I'm trying to find the right one.
Yeah. So I got one did surprised emoji for hallucinations. And the other takers, or most people seem to be having trouble finding their emojis. But it's in the chat bar.
Okay,
What do
so
you think,
we
Lori?
have,
Do you have a guess?
I think it's E. I'm guessing E, but I have a lot of A's coming in the chat and a couple C's and a couple E's.
Okay. All right. Well, you win the prize, Lori. It's all of the above. So all of these symptoms over the course of the illness are seen in more than half of individuals. And in particular, early on, mood and anxiety disorders. So one of the challenges when people have low dopamine, it can make you feel profoundly depressed. It can affect anxiety level. And so sometimes when we're first starting treatment for Parkinson's, we will use levodopa to boost dopamine to help both with motor symptoms, but also mood symptoms. The challenge is when somebody has the more aggressive form and they have early problems with hallucinations and delusions, then we have to be very careful and monitor for worsening of those symptoms when we're replacing dopamine.
We have a question from Dr. Churn.
Go ahead.
He wanted to know if you could comment on the hereditary dementia, what hereditary dementia could be.
Okay, so hereditary dementia is a broad topic. When it comes to people where Lewy body dementia seems to be more common in the family, there are just a small list of genes that may predispose both to Parkinson's disease and Parkinson's with early dementia, or even dementia with Lewy bodies. one gene that's very, very rare, actually. It has a mutation in the alpha-synuclein gene itself. And even rarer still is having an extra copy of the gene for alpha-synuclein. We call it duplication or triplication. The most common risk factor, but it doesn't have full penetrance, so it's not what we call an autosomal dominant pattern of inheritance, is a mutation in the gene where if you have two mutations, you would get a condition called Gaucher's disease, Gaucher, called the GBA gene for short. It codes for glucocerebrosidase. So one mutation in that gene, GBA, increases the lifetime risk of Parkinson's, and also people who do develop Parkinson's are more prone to earlier dementia. It increases lifetime risk to well above 10%, but it's still not 50%. And it's still not in that kind of 70 to 85% range we see with the most common hereditary risk factor for Parkinson's called LRRK2. So GBA is probably the most common risk factor for Lewy body dementia, but it still doesn't have strong penetrance, if you will.
And this
So
is
there
why
are
I'm
many families out there. Yeah.
So
Go
just
ahead.
stressing enough because people get tormented because they have family members who have dementia, Parkinson's disease, and I emphasize that there's not really really high, hereditary
Right.
percentage of this.
Yeah, I think that's very important is when somebody mentions their family history, when it comes to something like Huntington's disease, family history is very, very important because that's a condition most, has full penetrance. We'll touch on that in a moment, actually. But when it comes to Parkinson's, in most cases, people don't have a mutation that has full penetrance or that's strongly hereditary. So we can often reassure people just because your parent or grandparent had Lewy body dementia doesn't mean that you're at high risk for it. But it's still, family history is still important. And we always, as those clinicians in the group, we want to pay close attention to family history when kind of formulating our differential. I think the topic of hereditary dementia, we could talk a whole hour on, but I think for the purpose of Lewy body, that's where I'll kind of pause. And then before I move on to the next topic, one thing I want to point out is, schizophrenia, psychosis definitely can present later in life. But when we have an individual who's over the age of 60, who has developed new onset of psychotic symptoms, we want to look carefully for core features that would raise concern for Lewy body dementia. In particular, if they have rest tremor, that's a very strong indicator. So if their arm or leg has a tremor that's shaking when it's fully supported at rest, you really want to get that movement disorder doc involved and kind of, look for the most likely explanation. If they have recurrent acting out of dreams while asleep, dream enactment behavior, that's a very strong predictor of Parkinson's or Lewy body dementia. And if they have a very poor sense of smell, that also can be an important predictor, but that's hard. We don't necessarily have scratch and sniff kits in the clinic just yet. But those are important features that are very strong predictors of who has something in the Parkinson's Lewy body family. And we want to just have a very high level of suspicion and look more carefully for this if psychosis develops after, late in life. Evelyn,
So
had a question.
we had a couple questions. One, it's interesting because with the sniff smell, didn't COVID mess that up? I mean, that threw in some noise factors,
Yeah, it's a
right?
good question. What we're seeing though is, because we follow people in, we have a brain donation program at our institute where people get assessments on an annual basis, motor exams for Parkinson's, but also do scratch and sniff smell test kits periodically. And what we're finding is COVID does cause a temporary decline in sense of smell. But if it's a permanent loss in sense of smell, that's still concerning that it could be a sign of neurodegenerative illness because a marked, profound loss of sense of smell later in life seems to be strongly linked, particularly when someone develops a dementia problem or motor symptoms with a Lewy body disorder, like Parkinson's Lewy body dementia.
Yeah. We have another question, and I'll preface it by saying you said if you're a very active sleeper. My husband can attest. I run marathons in my sleep, so watch out, Chuck. I may be, and as a physician, you'll know when you have to check my brain. But it's interesting that when it's later in life, you check organically for brain, disease organically versus in the early years. I think they try to psychiatrists try to make sure that they rule out organic disorder before they go on to behavioral health disorder. But later in life, it's rule out organic and you tilt heavily towards that. But we had a question, any preventative measures identified?
Short answer is no. However, as you know, and you probably heard in Alzheimer's disease, there have been some major advances where they're starting to use infusion therapies when people are in that prodromal stage. They call mild cognitive impairment, perhaps even earlier. In Parkinson's, the only thing we have to recommend are lifestyle measures. So, all the things that are healthy for your heart are healthy for your brain, sleep, good sleep habits, Mediterranean style diet, regular cardio and weight training exercise, but there isn't any proven preventive treatment. There's a big research initiative because specifically REM sleep behavior disorder, so not necessarily restless leg syndrome or other sleep disorders, but REM sleep behavior disorder is the one that's strongly linked with later development of Parkinson's and related conditions. So really the initiative right now, they have a catchy website. It's just mysmelltest.org. So anyone who's 60 or over can go to the website, get a free smell test kit in the mail. Up until recently, we were recruiting people separately who had recurrent dream enactment. But at this point, anyone who's 60 and over that has impaired sense of smell, anyone who's 40 and over that has REM sleep behavior disorder, is encouraged to, consider being involved in an observational study so we can really answer that question, why are these strongly linked with risk of Parkinson's, and then how do we test preventive therapies? So that's an important initiative we're involved with right now. Anything else on the Parkinson's?
Yeah. What do you classify as disrupted REM or not enough REM? For a typical adult, how much REM is considered good? Those of us that have Oura rings or Fitbits, we get that information every night.
Yeah, so I think that the thing to be crystal clear about is I'm not saying you're a sleep expert or here to tell you how much REM you should get. But when you see on TV the dream sequence where someone has a nightmare and then they jump themselves awake and shout out loud, that is a sign of pathology. That is not normal. So if you have a dream and you scream yourself awake, or you dream about a fight and you punch your bed partner, you dream that you're jumping off a cliff, you jump out of bed. And it's happening on a recurrent basis, so not just one time after starting an antidepressant, because serotonin reuptake inhibitors may sometimes trigger it when you first start them. But if this happens on a recurrent basis, it could be due to something called pseudo-REM sleep behavior disorder, where people with sleep apnea seem to act out a dream, but it goes away when they treat the apnea. But if you have a sleep study and you make sure the sleep doctor is looking to see whether your muscles are paralyzed during REM state sleep the way they should be, so something called REM sleep without atonia, if that isn't present, that's diagnostic for REM sleep behavior disorder. And that's associated with a minimum of 70% lifetime risk of developing either Parkinson's disease, Lewy body dementia, or a more aggressive illness called multiple system atrophy in a normal lifespan. So it's not quite a guarantee, but it's a very strong risk factor for neurodegenerative illness. And that's why we have this initiative to find anyone who's 40 or over who's willing to be followed in the study and figure out how do we prevent this. So this is kind of like the mild cognitive impairment of Alzheimer's. But we're still a long way off. We don't have any preventive therapy that's shown promise, even in the early stage of Parkinson's, preventing progression. So we're still a ways off of telling you what to do about it, other than, they're basically melatonin or clonazepam can suppress the dream enactment in some individuals, but there's no proven therapy to prevent you from later on getting one of these neurodegenerative illnesses, other than lifestyle measures that we should be doing anyway, and most of us in this group are very knowledgeable about.
There's some questions.
It's a really
One
hot
was,
topic. We can
yeah.
Go ahead.
There's another one about, is it diminished smell or smelling things that aren't present?
It can be either one. So people with severely impaired sense of smell also can have what we call phantosmia. So just like phantom, but osmia. So olfactory hallucinations. They may smell things burning or something foul. It's usually a noxious smell that isn't really there. And very often when people get the smell test kits in the mail, they say this test isn't fair because everything just smells like cardboard. Like they can't smell anything. So we just tell them to guess. So if you do the smell test, just guess, and by random chance, you're going to fall in the lowest quartile or quintile. So I had reserved, added several slides talking about some of the other movement disorders like Tourette's and Huntington's, but this was a really exciting hot topic. I'll go through those briefly because I think an important topic for the group is really talking about the movement disorder side effects of medications that are individuals with mental illness are likely to be exposed to, and how to anticipate and address that. So I'll just touch briefly on this is an example of like the common list of when we see someone who has extra involuntary movements that they can't control. This is kind of an algorithm that we as neurologists in the movement disorder space are using to determine which we call hyperkinetic movement disorder we're dealing with. And one of the most common by far is tremor. So people with Parkinson's and related conditions have tremor, versus rest tremor. But another really common condition that can start in childhood, but also rarely can be a complication of a neurological illness, are the tics. So I wanted to touch briefly on this specific area because what we call the psychiatric comorbidities are so extremely common. And these are repetitive movements or sounds, so people can sniff, they may shake their head, they may make humming or grunting noises, not necessarily full words, but those can also be present. And in the primary tic disorders, these usually start on average between 6 and 8 years old, and they may or may not have a combination of both movement and sound tics, motor and vocal tics. And if they have both and they start in childhood, so motor and vocal tics that start in childhood, that's usually diagnostic for Tourette syndrome if there's no evidence of a separate cause. But many people don't have Tourette's, but they just have chronic motor tics or chronic vocal tics. But it's broadly considered to be all part of the same syndrome, what we call a primary tic disorder. So some people are just wired differently, so they're more prone to tics. These often improve by adolescence or young adulthood, but many people still will experience recrudescence or return of tic symptoms during stressful epochs of their lifetime. And the reason this is so important for the group is most people with Tourette syndrome and related primary tic disorders have psychiatric comorbidities. 86% have at least one, more than half have 2 or more, and the 2 most common are the obsessive compulsive spectrum disorders, and then attention deficit with or without hyperactivity. And with a lot of neurological conditions, mood and anxiety disorders are really common, but Tourette's is unique in that the OCD and ADHD are so common, they're actually considered by many to be part of a triad. So we call the Tourette triad of tics, OCD, ADHD. And it's important for individuals who have these psychiatric comorbidities that they, have someone who's comfortable managing the psychiatric symptoms along with tics. And one important pitfall is some are afraid to treat the ADHD with, worry that the tics can worsen. But many of the ADHD medications still can be used safely in people who have Tourette's. Very often, people with Tourette's are more disabled by their anxiety, obsessive compulsive disorder symptoms. And when they're feeling overwhelmed and anxious, that can then drive worsening of tics. So oftentimes, treatment of these psychiatric symptoms, either with the neurologist if they're mild to moderate, or with a psychiatrist if they're more severe, can also be helpful for their tics and Tourette's. One of the areas that can be really confusing for general neurologists, and where people in the movement disorder especially get involved, is when people have more continuous involuntary movements, what we call dyskinesias or chorea. These are really continuous involuntary movements that, in contrast with tics, they really can't suppress them. People with tics and Tourette's can often suppress this for long periods of time. Even if there's an urge that builds up, they can often still manage it in a group setting. When people have really continuous, writhing, irregular involuntary movements, and there's a really strong family history of people developing these along with neurodegenerative disease symptoms, this often prompts, particularly if there's a strong family history with in this case, autosomal dominant pattern of inheritance, so every other family member seem to have it, to really look for Huntington's disease. This is by far the most common hereditary neurodegenerative illness. And while average age of onset is 30 to 50, when it's inherited from the father, the size of the mutation can get larger. It's a polyglutamine repeat, CAG repeat, where if the expansion gets larger, it can occur earlier in life. And so we have many instances when it's inherited from the father where it can have a childhood onset, which is really tragic. On the flip side, there are expansion lengths that have incomplete penetrance and can have a very late age of onset. So there's no age where we can say someone's too old to have Huntington's. Very often people the diagnosis is missed because it starts after the age of 65. And, the clinicians just assume it has to be something else because they're, past the typical age of onset. People do eventually succumb to the neurodegenerative disease symptoms, but they are living longer and longer due to all the supportive care measures. We estimate 8 to 20 years is the average lifespan for when symptoms start. But it's really a triad of motor, psychiatric, and dementia or cognitive symptoms. It's more of a non-amnestic dementia, so more attention, executive function problems first. Memory loss is less, or memory is less affected. And in many instances, people can have profound changes in personality with much more irritability, uncharacteristic anger, losing their temper, and then feeling bad later about it. So profound personality changes, anxiety, obsessive compulsive symptoms also are extremely common, and suicide is almost 5 times more common in people with Huntington's than the general population. So people are much more prone, not just to depression, but suicidal behavior. And so this often management requires a partnership between all of the clinicians in the patient's care team, including neurology and often psychiatry. And depending on who's available in what region of the country, sometimes neurologists do a little of everything. Sometimes psychiatrists have to do a little of everything. Now, I mentioned the most common hyperkinetic movement disorder is tremor. And the most common cause of tremor after drug-induced is essential tremor. So we'll touch on drug-induced in a moment, but essential tremor can run in families. And when it does, it often has a much younger age of onset. But essential tremor is a tremor that is present mainly with activity and better at rest. It can also affect the head, the voice, even the face, the muscles around the mouth. And it's more common as we age. So rough prevalence is about 5% by 65. Some studies have estimated at least 20% by 80 or 85. And it's progressive, it's disabling, but it's not nearly as debilitating as the neurodegenerative illnesses. So it's not considered to be a neurodegenerative illness. And the cause is not entirely clear, but there may be changes within the cerebellum, the coordination center of the brain, particularly with what are called the T-type calcium channels. But right now, we just have a few medications that are used to treat essential tremor, like beta blockers. The less cardioselective, the more likely they are to be helpful. And then primidone and topiramate also can be helpful. So the problem is, people don't live in a vacuum. So very often when people come for second, third opinions with the movement disorder doctor, it's because they're not doing well with the typical treatment for essential tremor, or it's just unclear what's what, because they're taking a lot of different medicines and it's unclear which are side effects of medication, what's essential tremor, what raises concern for a neurodegenerative illness. Valproic acid and lithium are some of the most effective mood stabilizers for bipolar disorder, but they also themselves can cause pretty severe action tremor, and they can worsen essential tremor if the patient already has it. And oftentimes it's impossible to tell for sure whether they have essential tremor unless we could see them off the mood stabilizer, and sometimes that's just not possible. If people have very severe mania that we just don't feel comfortable switching their mood stabilizers around. The other challenge is even antidepressants can cause an increase in normal physiologic tremor. Most of us, if we're nervous enough, like if you have to give a speech in public, we will shake. You may have your hand, your leg, or even your voice shake when you're giving a speech. And that can be just due to normal physiologic tremor. But most antidepressants can worsen that, as can steroids and even a lot of the anti-rejection drugs for people who have had organ transplants can cause pretty profound physiologic tremor. And the only really effective treatment in that case is beta blockers. And some people can't always tolerate those. So this overall managing tremor often is not something that can just be done with the neurologist, but it really requires close communication with all the members of the care team, because very often it requires changing medicines that could affect other health conditions. So beta blockers are being used for the heart, or certain beta blockers could worsen asthma or contraindicated if someone's taking insulin. So then we need to make sure everyone's on the same page. You had a question from the group, Lori?
Yes. One question. You were talking earlier that it's hard to determine if it is the drugs, especially lithium, unless you stop the drugs, which may have bad effects. But
Right.
Are you saying that if someone has a drug-induced tremor, like from lithium, if they stop lithium, does the tremor go away, or is it forever?
If that's the cause, correct. So very often the temporal course, just taking a good history, which, some of my patients, they're so grateful if I spend a full half hour, let alone an hour with them on a new patient visit, because they say, last guy, it seemed like he had 1 foot all the way out the door before he came in. They literally get 5, if not, no more than 10 minutes with the doctor very often. And, even the best clinician can't always figure out what's going on unless they get the history straight. So an important question is just the temporal course. Did the tremor start before or after you started the mood stabilizer? Did it get worse when you increased the dose? These are basic common sense questions that I can't tell you how many times they've never been asked. And it's because some general neurologists, if they don't see 10 patients an hour, they don't make bank, So our approach is we kind of tailor, we triage the consults and decide how much time to allot based on the complexity of the visit, not based on how much we're going to make at the end of the day. But it really depends on the temporal course. Sometimes it's just unclear, and we're not, the mental health team is not comfortable changing the mood stabilizer, and the patient doesn't respond to the beta blocker, and we're kind of stuck. You can't always manage the tremor if the mood stabilizers make it worse and the patient has reasons why they can't take a beta blocker, because beta blockers are really the only effective therapy, and the more cardioselective, the less likely they are to help. So metoprolol is almost like placebo when it comes to treating tremor. Propranolol and atenolol can be helpful, but may have medical contraindications. But this is where at least having that conversation between the team is the first step. And it takes a lot of back and forth, copying in each other on our notes, and making sure, when things are complicated, we have a way to communicate between the mental health team and the neurology team. Yeah. More questions on that before we move on to the antipsychotic topic?
One question is, I've noticed in a family member that is on antipsychotic meds that it's pretty good, but I can tell before I ask if they've had energy drinks. And I'm like, did you have an energy drink today? Because then you can see the tremor. And I said that could just be from the energy drink itself, right? Making it worse.
Right. So, yeah, one thing, I often tell people is most movement disorders are worse when people are under stress or when they have a high level of emotional activation, whether they're anxious or excited. And that's true for tremor, but the fact that it's worse under stress doesn't necessarily tell us what the cause is. So that's more when it comes to tremor. If the tremor is very prominent at rest, when the arm's in their lap or the foot's on the floor, and then there's an improvement when they hold their hands out, it may eventually reemerge after a few seconds of holding the hands out or when they walk. But if it's very asymmetric or unilateral, and it's much worse at rest than with action, that suggests a Parkinsonian tremor. On the contrary, if the tremor is there with activity, when they hold their hands out, they shake. When they're using a pen or holding a cup, they shake. Then when they rest the hands in the lap, it goes away. That is not caused by the antipsychotic. That is not Parkinsonian tremor. And I can't tell you how many times general neurologists get this confused. So if somebody's taking an antipsychotic, that does not cause symmetric upper limb action tremor. That can be from a mood stabilizer, or it can be because they also have an essential tremor. It can be enhanced physiologic tremor due to the antidepressant. But the antipsychotic drugs block dopamine receptors. So they can cause symptoms that may be indistinguishable from Parkinson's disease, but the temporal course and whether the symptoms are symmetric may be helpful sometimes in differentiating. So in a very young individual who develops the slowness of movement, maybe if they're on a high dose potent antipsychotic, they even have excessive drooling, they're shuffling when they walk, and it's a very young patient, more likely than not, that's a dose-dependent side effect of the antipsychotic. But in an elderly, anyone 40 and over, if it comes on rather quickly when starting the antipsychotic, and it's very asymmetric or unilateral, that still can raise concern. We might be unmasking Parkinson's that would have become apparent eventually, but blocking the dopamine in the brain, this is the person who might have been compensating for a gradual degeneration in dopamine cells, but that antipsychotic basically unmasked Parkinson's or something in the Parkinson's family a little sooner. So that's where we often get involved, is helping differentiate, is this likely to be unmasking a neurodegenerative illness, or is it a side effect? But these drugs, antipsychotics, are not just used for schizophrenia anymore. Since the turn of the century, there have been tons of medications that come into common use and have been FDA approved to treat depression and bipolar disorder, and they're life-saving. So it's important that we don't, kind of fault, mental health team for prescribing them, because people need these medications. People with Alzheimer's, may respond really well to an antipsychotic for agitation. And we have our first FDA-approved drug now, Rexulti, that's actually well tolerated and very effective for agitation and Alzheimer's. It's a close cousin of Abilify or aripiprazole. These medications can often be used off-label, and we're not going to go off on a tangent about the pros and cons of using it for things like insomnia, anxiety, but we know these are often used off-label for that. And there are really only two antipsychotics that have no dopamine blocking activity. And that's pimavanserin, which is only used for Parkinson's psychosis, not effective for any of these other indications. And then Cobenfy was just the first breakthrough medication for schizophrenia. So the very first antipsychotic that does not block dopamine in the brain. So it uses a combination of trospium to block the effects of that block the peripheral nervous system side effects, and then this xanomeline in combination with trospium. It's only approved right now for schizophrenia, and it works on the acetylcholine system in the brain. So really, bottom line is, we need, when we're trying to advocate for someone who's taking an antipsychotic, to just be aware of what are the things that are likely to occur and that the healthcare team is going to be monitoring for when someone starts an antipsychotic medication. So one important problem I still see occasionally, but it's much better than it was 20 years ago, is people taking an antipsychotic will also be given cogentin or benztropine with the mistaken belief that it prevents long-term side effects. Benztropine can lessen the Parkinsonian side effects if they're problematic. But in terms of preventing an acute reaction, we call the acute dystonic reaction, where people kind of show up in the emergency room with their eyes rolling up and muscle spasms, it really is only necessary if someone's starting a strong antipsychotic like haloperidol, for example, in the first 2 weeks of taking that antipsychotic to prevent that acute reaction. But we really should only be giving benztropine cogentin in people where the Parkinsonian symptoms are problematic. And very often we see it given to patients where it's really not indicated. And later on, if they develop tardive dyskinesia, it can make tardive dyskinesia worse. It may even increase the risk of tardive dyskinesia. And in older patients, it causes a lot of side effects, so that may really decrease their willingness to stay on their medications. Now, as we increase the dose of the antipsychotic, there are dose-dependent side effects. So not just the Parkinsonian side effects, but what we call akathisia. So it's not just restless leg, but the whole body feels restless. And really common with some of the newer drugs like aripiprazole, Abilify, even with risperidone. But that can increase as we go up on dose. And it often remits just by changing to a different antipsychotic. So these are dose-dependent side effects where it's important to bring the attention of the mental health team, but if they're not sure how to manage it, or they're not sure if they're dealing with Parkinson's versus a side effect, we may recommend a special scan called a DAT scan in some circumstances. In other circumstances, we may already have enough symptoms present where we're very clear this is Lewy body dementia, or very clear this is Parkinson's. So this is a very good reason to involve the movement disorder team directly, is if you're concerned we might be unmasking a neurodegenerative illness and that the Parkinsonian symptoms aren't just a side effect. The other thing that often happens that's confusing is when someone stops a more potent antipsychotic, like one of the first generation older ones like haloperidol, but even aripiprazole or risperidone, if they stop it quickly, people can have dyskinesia where if they reintroduce the medication and wean more gradually, the dyskinesia goes away. So we always want to make a gradual taper off one onto the other when we're switching. But if someone just had to abruptly stop a medicine and develops dyskinesia, it could be something called withdrawal emergent. But the tardive syndromes are really, really challenging. So these are the ones we'll just jump ahead and talk about. The tardive syndromes are more common the older the patient is. They're more common if the patient is on a more potent agent, and they can only occur if the person is exposed to the medication long term. So if someone, took the medicine just one time or just for a few days and has never taken a dopamine blocking drug before, that's probably not tardive dyskinesia, unless they did take something they weren't aware was an antipsychotic. Now they're re-exposed and now they have it. But it seems to be that it has to do with blocking dopamine receptors for a long period of time. In people who are predisposed to this, it causes changes in the motor circuits of the brain. So an increase in dopamine receptor, the dopamine receptor becomes more sensitive, but also other cells in the brain that are supposed to balance out dopamine activity, cells we call the GABA cells, also may be damaged long term. So people are 60 or over, postmenopausal, if they have serious mental illness where they also have substance abuse, then any of these are signs that they're going to be at higher risk, and they should be monitored even more carefully for tardive dyskinesia. And we have a structured exam that we do, both psychiatrists or neurologists, if we're monitoring, called the abnormal involuntary movement scale. So one protective factor, people who have Tourette's, chronic tic disorder, and are taking an antipsychotic just for their tics, are much less prone to tardive dyskinesia. Doesn't mean they're immune, but it's much less likely to occur if the drug is being used for tics. But the longer they've taken the medication and the more potent it is, and if they've had other movement disorder side effects, that also increases the risk. The risk is 4 to 5% annually, and the prevalence is about 7% in people who have only taken newer antipsychotics, 30% in those who have been taking the potent first-generation antipsychotics. But most people are in this middle category where, when they've been in the hospital, they've had to take first-generation antipsychotics to stabilize them, but currently they're taking a newer second-generation antipsychotic. The prevalence of tardive dyskinesia conservatively is about 1 in 5, 20% in those individuals. So it's very common, and it can be really disabling. I mean, just imagine for people who are trying to stay in the workforce, trying to be a teacher and knowing your kids are probably making fun of the fact you can't control that you're making these faces all the time. Most common dyskinesia is a repetitive puckering of the lips, facial twitching, followed by piano playing movements in the fingers, repetitive body rocking, up and down movements of the feet at the ankles. But it can cause very painful involuntary twisting postures of the neck or entire spine. It can cause involuntary eye closing called blepharospasm. It can cause profound akathisia, so restless body symptoms that don't go away even when we treat the tardive dyskinesia. And so when people start to develop tardive dyskinesia, that's where the healthcare team has to make decisions about potentially switching to a less potent agent that's less likely to make it worse over time, but also deciding whether to treat it. So while we may use benztropine cogentin to treat Parkinsonian side effects, benztropine cogentin can actually worsen tardive dyskinesia, and actually we may improve the dyskinesia by discontinuing it. There are 2 FDA-approved drugs now that work by blocking the brain cells, the dopamine cells' ability to store dopamine. So they're actually reducing the amount of dopamine that's released, and so they can reduce the involuntary movements without having an antipsychotic effect, so without actually making the tardive dyskinesia worse over time the way an antipsychotic could if we're not treating tardive dyskinesia. People can be treated long-term with these medications, so we now have good 7, 8, even 10 years of experience with these medications since the initial trials and since they first came out. So they first came out 2017, 2018, but we have people who have been followed in some of the trials since about 2015. But these are really the only FDA-approved drugs, and the challenge is they're still very expensive. In most cases, they're reasonably well tolerated, though they can be sedating. The off-label, less expensive one, tetrabenazine, is usually more sedating, and it can worsen depression or anxiety, so it's not commonly used. Amantadine may be used off-label, but it's not usually as effective, has very limited evidence for its use. I often get involved not just helping decide how to, fine tune these medicines that most of the mental health colleagues are familiar with, but if people aren't doing well with a specific, we call it tardive dystonia, so involuntary jaw clenching that's causing dental wear or pain, involuntary twisting postures of the neck called cervical dystonia, involuntary eye closure, tardive blepharospasm. I often, or other movement disorder or colleagues or general neurologists get involved to give injection treatments with botulinum toxins like Botox. And it's very rare that we have to resort to this, but for very severe tardive dyskinesia with a lot of involuntary twisting postures of the neck and spine, called tardive dystonia, deep brain stimulation can be helpful. But it's very rarely needed for tardive dyskinesia. So that's really our kind of treatment overview. I really recommend, if things aren't adding up, and particularly if there's concern that someone could actually have unmasking of neurodegenerative illness and a delay in that diagnosis could be harmful, that's a good reason to just get a movement disorder specialist involved directly. If they're seeing a general neurologist but things aren't adding up, that's another good reason. And if they need injection treatments, like I just mentioned, that's something that movement disorder specialists are all trained to do. They can be hard to locate someone in the general neurology group that offers it. We're one of a few multidisciplinary clinics in the Valley. So along with just a few of the other academically oriented programs, we also have a memory clinic right alongside the movement disorder clinic. So when people have neurodegenerative illness that can cause both memory and movement disorders, we often have a team approach to that. We have the neuropsychological testing on site and clinical trials for people that want to volunteer, other clinical research right here on site. We had a question from Rachel.
Hey there, can you hear me?
Yes.
Yes.
So there's like another sort of category of things that we deal with a lot with clozapine, and it's these myoclonic jerks or atonic incidents where it's like dropping things or stumbling, and I guess those are more in the seizure realm, and so we're kind of treating those with seizure disorders. Is there any really kind of easy way to tell when that's happening? Because a lot of times it gets confused with other types of movement disorder, or even confused with orthostasis that can also happen on the clozapine.
Right.
So maybe you can talk about clozapine unique movement situations.
Yeah. This is why I love doing these, kind of meetings, because sometimes I hear about things I wasn't familiar with, and get new collaboration. So I personally, I use clozapine mainly, of course, in people with Parkinson's, Lewy body dementia-related psychosis. I'm using much lower doses than people are using in psychiatric clinics. So it's rare for me to go above 25 milligrams a day in that population. I was not aware of myoclonus as a side effect. I was always taught, and I've seen my own experience, that higher dose opiates or people with renal insufficiency taking opiates could develop myoclonus as a side effect. And I know there are a whole host of drugs where myoclonus can be a potential side effect. So I agree, first thing that comes to mind would be, is this actually due to orthostatic hypotension? But if the patient's sitting in a chair and having myoclonic jerks, or they're having asterixis, which is a sudden loss of muscle tone, so negative myoclonus, that would suggest this could be a drug-induced myoclonus. So that's something where, the first step is we should probably, I'd love to confer offline and kind of clarify, what's the prevalence, and then kind of brainstorm a little. Has there been research on prevalence, and has there been research on what's the best therapeutic approach? Our general approach when people have myoclonus that's secondary to a drug has been the question, can we adjust dose or switch drug? But in clozapine, that's not usually an option, because this is often a last resort drug. where, it's the best remaining option for the individual. And when it's somebody that has secondary myoclonus where we can't take them off the medication that's causing it, like with a high dose opiate, or if it's secondary to a metabolic disorder like liver failure, renal insufficiency, then the GABAergic drugs, so either levetiracetam, zonisamide, or benzodiazepines, are the main treatment options that, based on clinical experience and case series, we've seen efficacy, but there aren't any well-designed clinical trials or an FDA-approved treatment specifically for myoclonus. So I think it would be a really wonderful topic to really, hear more about offline, separate from the group, and decide, is there really any literature on prevalence of clozapine-associated myoclonus? We'd have to kind of do a deep dive in the PubMed literature because it wasn't something I was familiar with.
Yeah, and
Thank you.
I'm an administrator for a big clozapine clinic out of New York, and then a smaller one here in Arizona. And it's definitely less than 5%, but when it happens, it's a hassle. So, it's like high doses of lamotrigine, and then beyond that, it's the benzos and different things that we're trying. So it's a tough one.
Yeah. There have been reports of lamotrigine, phenytoin, any of the sodium channel blocking drugs actually causing myoclonus. So I would usually start with Keppra or zonisamide if the benzos have failed or contraindicated. Maybe even start with those first line. But I think you're in a unique position where if it's never been published, just actually running a search of the database or the registry and determining the prevalence would really be helpful to people across the world to know this is an important side effect to watch for, and also if there's a specific dose threshold where it's being seen, and then to also be able to report your experience with each of these classes of drug as to what proportion of individuals tolerated or responded. But I think you're in a very unique position because you have a lot more patients taking clozapine than most mental health professionals or neurologists in the country, if not the world.
Yeah, definitely. I put my email in the chat and I'll get in touch with you separately. Thanks.
Yeah. Okay, we
you.
also had an earlier question about Lewy body dementia. They said, do mood symptoms ever show as alteration between hypomanic speech and no sleep for 2 days, alternating with sleep for most of 72 hours, followed by more normal behavior?
Yeah, Lewy body dementia mania is very unusual. So that still would make me worried about undiagnosed bipolar disorder.
Bipolar, or substance use, right?
Right. What we do see, however, we don't have time to go into all the nuts and bolts of Parkinson's, but people taking dopamine agonist medication like pramipexole, ropinirole, Nupropatch, Mirapex, Requip, or the old brand names, are prone to a side effect called impulse control disorder. And it's not necessarily manic the way you're describing, but it's usually addictive behavior that's used to be early on. We would hear about compulsive gambling, hypersexuality being most common, but now it seems to be a lot of shopping behaviors, and of course, internet usage, emailing, and just researching on the internet all night long. So it's still a consideration, but if someone has new onset manic symptoms, the question then is, well, was there something that was missed earlier in life and now it's just worse for other reasons like medications or substance abuse? But also frontotemporal dementia can also cause profound changes in behavior. So it's not necessarily manic symptoms, it's more just impulsivity, being socially inappropriate, for example. Yeah.
No.
Complicated.
Yeah. No, we also typically will wrap up the slide deck as a PDF and put it on the site for those that have missed or had to step away because a lot of times they have other obligations or challenges during this time frame. So if you could send me your slide deck, either wrapped as a PDF or I'll wrap it and then load it up on our site.
I sure will. Yeah.
Any last questions
Well,
for the doctor? Well, we want to thank you. It's been eye-opening, and you came highly recommended from some of the psychiatrists that currently refer to you for movement disorder for their psychiatric patients. But it really was a lot of good information, and we want to thank you.
yeah, thanks for the opportunity. It's been my pleasure.
Thank you. And you have thanks from the chat for the great presentation.
Thanks
Thank
a
you.
lot. Great to meet you all virtually.
Yes. Okay. Thank you.
Take
Does
care.
anyone have any last thoughts or anything that you'd like for the last few minutes of the meeting?
I have one last question.
Okay.
If somebody is on a antipsychotic, like a typical or a second generation like Risperdal or something, and they get TD, could switching them to clozapine help at that point?
Yeah, it's a great question. Potentially, yes. So switching to clozapine, which is kind of the most atypical of the atypicals, can potentially improve the tardive dyskinesia, but it may still, unfortunately, be permanent for many individuals. I'll never forget one of my patients who I had to give Botox for tardive blepharospasm. He also had twitching in the face and other dyskinesias that weren't as problematic, but it was the eye closing spasms that were really problematic. He hated it. I never had someone scream so loud every time they got their shots. But when he was able to switch to clozapine, he improved enough that he didn't need his shots anymore. So I've definitely seen it in my clinical experience, but I've also heard of many patients that unfortunately don't improve enough after switching to clozapine to where they don't still need treatment for the tardive dyskinesia if it was already indicated.
I have a question. I don't know how to raise my hand. My son's on lithium. He's been on lithium for quite a while, at least 10 years. And he was starting to get some tremors. So his doctor lessened one of the things. And I think it's helped with the tremors or whatever. But he seems to be hearing the voices a little bit more. And he seems to be having a lot more conversation. And is that from the lessening of the lithium, or is there something else that might be a good transition for him?
Yeah, so first of all, very important to bring that to his psychiatrist's attention. From what I understand, but no way am I trying to second guess his psychiatrist, some people who have mania also have hallucinations or delusions when they're manic. There also can be other, diagnosis is not always a one and done. Sometimes our diagnosis is still kind of evolving as we get to know the patient. So sometimes people do need an antipsychotic as a mood stabilizer, or if they have schizophrenia, they obviously need an antipsychotic. So the main thing is just to bring it up with his psychiatrist and let his psychiatrist be the judge. But we very often have people who can't get away with just lithium alone, but if they have severe bipolar disorder, also need an antipsychotic as a mood stabilizer.
Yeah, he takes Risperdal also. Thank you.
Right.
Well,
That's a good example. Yeah.
Here's another question in the chat. In atypical Alzheimer's, is trouble walking part of the Alzheimer's, or could it be Lewy body?
So, yeah, people often have more than one condition. So people who have a lot of shuffling of the gait particularly if they have rest tremor, may have a combination of Alzheimer's and Lewy body dementia. So yes, that's something where, we need to have a neurologist involved and kind of use our algorithms and tests to decide if they have one or more of these conditions. But absolutely, if there's early on, if there's a shuffling and a gait problem, it could be a Parkinsonian disorder. It could be, there are other neurological conditions that might show up on the brain scans, but definitely a good reason to have a neurologist involved to differentiate.
Thank you again. Thank you very much. And if you can send me your slides, I'll get that updated and loaded up on the site. I want to thank you again,
got it.
and it was a pleasure having you. Hopefully you can attend whenever we have a real gathering again instead of virtual. And we would love to show our appreciation for taking the time to educate us in your specialty.
All right, thanks for having me. Y'all have a great evening. Good night.
You too. Thanks, everyone. See you soon.